My name is Dr. Zara Jesser, and I am a specialist optometrist in low vision, and we are here today at Action for Blind People at RNIB in London. By the end of the session today, we hope that you will have a better understanding of the principles of a low vision assessment, a better understanding of the impact of the sight loss on activities of daily living, a better understanding of the basic principles of low vision aids, and also a better understanding of the UK sight loss pathway. Why is this all so important? Well, visual impairment and the need for rehab are becoming increasingly important, and this is because of improving healthcare. We have a larger proportion of people in the older age groups, and this means a higher prevalence of visual impairment. So how do we define low vision? We define a person as having low vision when they find it hard to see things as clearly as they would like, even though they may have had an eye examination and up-to-date glasses. It may include people that are registered as being severely sight impaired, but it's not limited to this group of people. So we can define low vision as vision that, when corrected by optimal refractive correction, is not adequate for the patient's needs. So now that we know what low vision is, how do we manage a patient in our practice that has low vision? Well, the first step is observation, observing the patient. Are they entering into your consulting room with support, or are they walking in unaided? Or are they feeling for a handrail? And we'll speak about this a little bit more later on. It is also important to take a detailed history and symptoms. Not only are we focusing on ophthalmic history, but also on whether the patient is living alone or with family. Are they living in a flat with lifts or a house with stairs? And all this is important for us in order to build up a picture of that patient. The ability to perform essential tasks should also be investigated. How is the patient coping with essential correspondence? Are they able to do the hobbies that they enjoy? And one or two open questions at the beginning of the assessment can help to identify areas of functional disability. And then a few targeted questions can help to identify areas where the patient really needs extra help. What are the practical steps that we can take to adapt our routine eye examination for our low vision patients? Well, it is important to have the appropriate charts available, especially when we're measuring acuities of less than 660. We know that electronic charts can measure VAs of up to 260, and handheld charts can measure VA to approximately 1/120. When assessing near VA, it's important to make a note of where the working distance is. It's also important to measure not only the smallest size print that the patient can see, but also the print that's actually comfortable for them to read. And this would be more indicative of what they can manage in their everyday life. You may also want to measure near VA on real-world tasks, for example newspapers, and also with and without a reading lamp. It's also standard practice in low vision to measure the near VA with a +4 add, as this corresponds to unit magnification and will be helpful when trying to work out what magnification is required. Our contrast sensitivity measurements are also important, as our visual interaction with the world involves having to resolve low contrast detail, and we'll come on to this later on. Historically, we know that visual acuity has been measured using the Snellen chart, and this has been extremely important and useful in screening for the common causes of visual impairment. It's also been really useful in the detection of uncorrected refractive error. However, within low vision, we tend to use logarithmic acuity charts, for example the Bailey-Lovie or the EDTRS. And there are a number of reasons for this, but probably the most important reason is that they have more letters at the lower levels of acuity. So for example, between 660 and 624, there are 15 letters on the EDTRS. And if we compare this to the Snellen chart that would only have perhaps 2 letters, using the EDTRS or a Logmar chart will enable us to have a more precise measurement of VA. And will also give some encouragement to a low vision patient who would otherwise only be able to read perhaps the top letter on a Snellen chart. It's important to remember that the vast majority of our interaction with the world involves resolving low contrast detail. So it is important that we do measure contrast sensitivity, especially in patients where reported visual performance is less than the VA would suggest. It's also important in explaining to patients the impact of visual impairment. The same principles of Logmar also apply to near vision. It's important to remember that when we're measuring acuity in the distance, it involves asking the patient to name the letter or to match the letter or the symbol. But in near VA, we're asking them to make sense of the letters and pronounce what they see as a recognized word. And this requires higher order cortical processing. The process is even more complicated as the task of reading not only involves having to pronounce the word, but altering your delivery in order to reflect meaning and context. And then the process of comprehending what has been read is also dependent on reading speed, which in turn is dependent on eye movement control. So here at Action, we use the Pelly-Robson. And this chart, when used at 1 meter, is designed to assess contrast sensitivity at the peak of the contrast sensitivity function curve and is best placed to correlate with activities of daily living where we know contrast sensitivity can be an issue. Refraction should always be performed as part of a low vision assessment, but the subjective routine may need to be modified. Using a ±1 cross-sill is often really useful, as is using larger steps when we check the spherical correction. It is important that we don't dwell on tasks that the person isn't able to do. For example, spending too long on a subjective refraction on an eye that perhaps only sees 260 is quite demoralizing for the patient, particularly if the other eye has a better VA. From a patient's perspective, it is important to make an appropriate choice of where to place the test chart initially. We know that visual field testing can be quite a challenge with people that have reduced vision, and therefore it is important to consider using a larger spot size on automated field instruments, or even using a coarser field assessment, for example confrontation or even a tangent screen. Moving on to magnification, as a rule of thumb, it is the minimum amount of magnification that is required to perform a task fluently. That's the magnification that's prescribed. If we increase the magnification further, it's important to note that this will reduce the field of view and will also make the magnifier quite hard to use.
Hello, my name's Louise Gow. I'm the clinical lead optometrist for the low vision services at Action for Blind People. There are 4 ways in which to enlarge an image. The first is relative distance magnification. This magnification is created by moving the object or the image closer to the eye. This includes strategies such as sitting closer to the television or using optical aids to move the image closer to the eye. The result of reducing the object viewing distance is to increase the angular subtents of the object at the pupil entrance. An object at an initial reference working distance of 40 centimetres produces a retinal image twice as large when viewed at 20 centimetres. A presbyopic eye would require an optical aid to view the object at 20 centimetres. The second type of magnification is relative size enlargement. This type of magnification is achieved by increasing the size of the object while the working distance remains the same. Examples of this would be large print books, larger TV screens, text enlargement such as Zoom Text or Windows Magnifier. Measurement is by direct scale comparison. A bank statement that is normally printed in N12, if generated in N24, would represent a relative size enlargement of 24/12, which is 2 times. The third type of magnification is electronic enlargement. This type of enlargement is achieved by projecting or electronically changing an image to increase the angular subtense at the eye. An example of this would be CCTV. The magnification is measured directly by comparing the new height of the image with the original height of the object. Advantages of this type would be the ability to magnify at a normal working distance, which helps patients that struggle to cope with shorter working distances, as well as allowing a large range of magnification suitable for patients with progressive or variable sight loss. It has the added advantage that it can be used to enhance contrast. The final type of magnification is called angular enlargement. This is the ratio of the angle subtended by the image through a telescopic aid compared to its subtense viewed directly. Using a telescopic aid enables this to be achieved without a change of the vergence of light, which enables image magnification at long distances. Of course, these types of magnification can be combined. For instance, a telescope with a plus near cap combines angular enlargement with relative distance enlargement. So there are several methods used to predict the likely magnification needed for a task. One method is to divide the target VA by the VA achievable with a +4 add. An alternative way of thinking of this is that, for instance, N18 is ×3 the size of N6, so you would need ×3 magnification to spot read N6. For example, a person who wants to read a newspaper print size of N8 at 25 centimetres but can only manage N16 with a +4 add at 25 centimetres, then the magnification required would be 16/8 or 2 times. This would in theory just about enable him to see N8, but it is important to remember that fluent reading would not be possible and an acuity reserve of at least ×2 should be allowed. Therefore, ×4 might be more appropriate. We work out magnification based on a +4 lens giving unit magnification at 25 centimetres. The magnification of a device is considered to be f/4, where f is the power in diopters, assuming a viewing distance of 25 centimetres. It should be noted that some manufacturers mark their devices using the formula f/4 + 1, which can be confusing, and so we tend simply to refer to the dioptric values. So at this point we should mention high adds. These are strong reading spectacles that enable the object to be viewed at a shorter working distance and with the resulting magnifying effect. It should be noted that while the high-powered lenses give magnification, they get progressively harder to use due to the convergence required. In order to resolve this, base-in prism is often used, and sometimes one lens is frosted so that the spectacles can be used monocularly. Some may dislike the short working distance, but others prefer that it is a hands-free device. So what is the impact of low vision on a person's life? As optometrists, we are skilled at measuring and quantifying vision. We have the knowledge to prescribe lenses that focus and to magnify. However, we do need to combine this technical knowledge with the needs and experience of sight loss for each individual. In a room full of people with ARMD, you will find there are of course similarities in their experiences, but the impact on their circumstances can be extremely varied. The factors that influence this would be their age, their health, occupation of the patient, their support network, their marital status and the stage of sight loss, and certainly the things that they used to enjoy doing before their vision became impaired. Think of them as a whole person and target your help for those activities that either put them at risk, such as misreading medication packages, or activities that improve their quality of life, such as going out or their old hobbies. The importance of asking the right questions, of finding out what tasks are important to them, should therefore be apparent. This is a simulation of central vision loss. The exact nature of the loss varies from individual to individual. There may be a black spot, or distortion, or smudges, or grey or white haze centrally. Some people notice that looking slightly off-centre they can find a sharper image. This is called eccentric viewing, and in some cases this can be taught in order for the patient to read slightly more fluently. Central vision loss has its greatest impact on tasks that involve detail, such as reading. However, many patients mention the difficulty with face recognition is amongst the most upsetting effect. This simulation is of extensive visual field loss. Notice how difficult it is to tell how many items there are on the screen and their exact locations. If you translate that now into a situation such as going into a big station, having to find the ticket machines, locate the indicator board, read the indicator board, locate the platform, whilst avoiding people rushing around you. It's important to remember that visual field loss types vary also, and some can be compensated for by head movement while others can't. This means the impact is varied for each patient. Hemianopia is a special case where sight loss can be suddenly and profoundly life-changing. The obvious impairment is regarding driving and mobility. However, there is a subset that have visual neglect. This is where the person is completely unaware that the affected side exists. We mentioned earlier the benefits of measuring contrast sensitivity. Our world is not black and white, and therefore some details will stand out clearly, whereas others will be significantly impaired. See in the simulation how the butterflies remain, but the stairs disappear with contrast changes. Reduced contrast affects mobility firstly, but can also affect the use of computers and reading. They may also have problems in bright light or glare. So overall, it is important to put together the patient's needs, their ability to recognise faces, read and self-medicate, their preferred activities such as hobbies and work, with their type of sight loss. Remember also the emotional impact that sight loss has is devastating, and that needs to be taken into consideration. So how can we help our patients? The UK Sight Loss Pathway is the considered best practice model of services for people with sight loss. We will be talking more about this shortly, but firstly it is important that you understand the registration process. There are two categories of registration: sight impaired and severely sight impaired, previously known as partially sighted and blind. Severely sight impaired is considered to be those patients whose visual acuity is less than 360. There are other groups that include visual field loss also. Sight impaired is considered to be those patients whose visual acuity falls between 360 and 660. And again, there are groups that include visual field loss. It's worth remembering that the consultants consider this on a case-by-case basis, and therefore these are not concrete. If you feel that a patient is a special case that doesn't fall into these categories, they might still be considered for registration if you explain the circumstances to the consultant. The process of registration is two-part. The consultant signs the Certificate of Visual Impairment, or the CVI, and this is sent to the social services who register the patient as sight impaired. If the person has been discharged by the hospital, you will need to refer them back to have this done. Do not assume that because they have been discharged, this has been discussed. Always discuss it with patients that are eligible, as many do not understand what it is or why they should consider it. There are many reasons why registration is beneficial, and these can be found in the RNIB booklet called The Benefits of Registration. It can be downloaded or requested in printed formats. It is difficult to keep track of the benefits changes, and therefore this booklet is a very useful resource. There are some benefits that are universal, whereas others are limited to severely sight impaired only. There are no automatic financial benefits, although registration helps with the application for these sorts of benefits. It is good also to consider the wider implications of registration. Long-term planning of service provision is based on the registration numbers of people living with particular conditions. If it can be demonstrated that a service is required, then it is protected. The UK Sight Loss Pathway is a UK vision strategy initiative to help develop best practice model for all. It explains how different services can support a person and link together to work in a holistic manner. Early intervention with rehabilitation and reablement are highlighted as priorities. Optometrists are important stakeholders who can offer support at the point of diagnosis and throughout the sight loss process, via contact in optometry practices and in hospital departments such as low vision. The LVL is a leaflet that can be filled in with the patient's permission or given to the patient to fill out for themselves. It is a request for help from social services, and the patient does not have to be registered as sight impaired in order to use these services. It is hoped that following this guideline will reduce the numbers of patients that present in emotional or financial crisis, or who will suffer falls or medical incidents as a result of their vision. It is based on evidence from the Seeing It My Way research that asked people with sight loss what their priorities were, and the 10 Seeing It My Way outcomes were developed. The UK Sight Loss Pathway is designed to address these 10 needs. Working together within the Sight Loss Pathway means multidisciplinary working and local planning to result in better outcomes, such as quicker access to the right support by teamwork and the effective use of resources to maximise independence and promote eye health. These are just some of the professionals that can be involved in the pathway, some of whom you'll be very familiar with, such as optometrists, ophthalmologists, orthoptists. Some, however, you may be less familiar with, such as the ECLOs. This stands for Eye Clinic Liaison Officers. They're often based within hospitals, and they're first port of call for patients that have been diagnosed with sight loss. They signpost patients to other services and facilitate them accessing the right services at the right moment. Here at Action, we have ILCOs. This stands for Independent Living Coordinator. They help people to fill in forms, to apply for jobs, and to ensure that they're getting the right benefits. We also have assistive technology experts that help people learn to use new technology, such as iPhones, and assistive technology software, such as ZoomText.
My name's Judith Harrison and I'm Community Services Manager here at Envision. Envision is a local charity serving the people of Blackpool, Fylde and Wyre areas, regardless of age or means. We're here to help and to support anybody who has reduced vision. From the Low Vision Centre, we have a team working, including an ECLO, an Eye Clinic Liaison Officer.
My name is Linda Setti and I'm the Eye Clinic Liaison Officer with the Blind Society here at Envision. My role is dual-based, so I have a presence both here in the Low Vision Centre and up at the local hospital and in the community hospitals as well in the Fylde Coast. I have a presence on the clinics at the hospital, and I'm there really to support a patient when they are going to see the consultant. For many patients, it's quite a daunting prospect to go along to see the consultant, and they may have many questions that they want to ask, whether it's about their treatment or about the condition that they have. And if they feel that they can't do that, then obviously they will ask me and I'll go in with them. I'll also take some notes down and then obviously ask the questions that are relevant to that patient. After which we can usually spend a little bit of time with the patient and myself just going through what's been said, so that when the patient actually goes home, they are fully conversed with what's happening to them. And obviously I talk about the resource centre that we have here and what benefits we can offer them and how we can help to keep them independent, because that is obviously the aim at the end of the day. I do visit patients on the wards, so if a family member or even the ward staff, if they let me know that one of our clients, or even if it's not a client that we know of, if they have a patient who is an inpatient and is probably having a few difficulties, struggling a little bit, then I will go onto the ward to see that person. If they are known to us and I know they're going into hospital, I will go onto the ward really so that I can explain to the staff that this particular patient needs a little bit of extra help, because when you have reduced vision and you live at home, you're very familiar where everything is. So you will know whereabouts things are in the kitchen and just the general surroundings that you're living in. Once you're taken into hospital, and especially with the sight loss, we find that some patients can get a little disorientated. And so really talking to the staff, explaining what difficulties they may experience, and just letting them know they might need a little bit of extra help. I do have a bed hook, a place those in the ward so that the staff can actually put them at the patient's bed, so that anybody coming towards that patient would realise that they have a visual impairment and therefore they would need extra help. As with any organisation, you know, where appointments are concerned, appointments can get postponed, cancelled. And for some of our clients, it's quite imperative that their appointments are kept within a certain time scale, a time frame. They must go to see the consultant within so many weeks. And if the hospital have postponed those appointments, I do tend to take that on board and try and get those brought back into line, especially where sort of injection treatments concerned, the Lucentis injection. If they're on that programme, then time is really of the essence and they need those injections in a timely manner. So I would be on to them to sort of try and get those put back into place. When a patient is registered as either sight impaired or severely sight impaired, their registration document at the hospital is sent up to the secretary's office with the bulk of their notes, their file. If I haven't seen that patient on clinic, then all those notes are kept until I've actually seen them. So I would take note of the patient's details, and then when I come back down to the centre here, it is at that point that I would then make contact on the telephone with the patient. And during that conversation, I would be able to gather the difficulties that maybe they are experiencing, that the sight loss is giving rise to whilst they are at home and out and about. And at that point, I can then refer, if appropriate, over to social services, to the rehabilitation officer for the visually impaired, to actually contact the patient and go out and see them at home. Optometrists can, if they feel it's appropriate, if they're seeing a patient and they feel that that patient may need or benefit from our services, they can also refer into us here. The private Lancashire Eye Clinic in Lytham, they refer patients into me also. So I do get referrals not just from the Blackpool Hospital, but from other areas as well, and also from self-referrals. People can just ring up. It's as simple as that.
For some people, they may be socially isolated, so we have things like a social centre where people come in once a fortnight and spend a day with us, and they have a hot meal and entertainment, and door-to-door transport as well is included in that, because I think transport for anybody with reduced vision is quite difficult. Do they have the confidence to travel by public transport? Not always. So if we can help them with that, we do. For the more active people, we have an activity group, so they do outings. They'll go to maybe Chester and they go to a garden centre and various things like that. What they want to do. I think we always have to come back to what the individuals want. It's not what we want for them, it's what the individuals actually want. Alongside the emotional support, it's also important that we provide services and equipment that will help to make life easier. We have a permanent display within the Low Vision Centre of equipment, and a lot of the ideas are very, very simple. Lighting and colour contrast are the two things that people can do for themselves right away. If we just take, for example, what do you eat your food off? Most people these days, white is very popular, and if you have a white plate with fish, mashed potato, chicken, it's going to disappear. But if you have a dark plate, then things are going to stand out more easily. With drinking vessels, having a plain glass with water in, out goes your hand and over it goes. If you can have a glass with a pattern on, then you've actually got something to aim for. People do get embarrassed and frustrated by the little things that can go wrong. So do they decorate their bathroom with the toothpaste when they're trying to get it on their brush? So is it easier to think round the problem and think, well, if I get a coloured toothpaste, and quite often you can get bright blue these days, and put it into a saucer or something like that, and then dip your brush into the toothpaste rather than try and do it the other way about. We had one lady who went to the hospital, and when she lay down on the examination couch, she was going for something other than her eyes, she looked down and she had odd shoes on. Very, very upsetting at the time, but if you just use a clothes peg to clip the shoes together, then it's just a way of organising things. So it's little things like that, but then through to the more sophisticated electronic reading aids, so that things are here for people to try. And again, what we say to them is, you know, if you're experiencing a problem, then get in touch with us, talk to us, and usually we can find some sort of solution. It won't be doing it in exactly the same way that they've done it previously, but with a few adjustments, then we can usually make things work.
Hello, my name is Brian Casey. I'm the low vision worker at Envision in the Resource Centre. My role mainly is to get people to look at magnifiers and technology, the main areas what I work in here. A little bit about my story. I'm visually impaired, severely sighted in both eyes. I had an accident about 25 years ago in one eye with a squash racket and a football in the other eye a year later, what made me visually impaired. My job at the Low Vision Centre is to show people magnifiers and to deal with referrals from the optometrists who sent out pink sheets after they have an LVA test. Then I follow up with them to check to see if they're getting on okay with them, and also showing magnifiers if they'd like to. Everything's possible when you're visually impaired these days with the technology. There's hardly anything you cannot do. And I think you just have to be positive and go with it. Don't worry about making mistakes.
There are a lot of things out in the environment to help people who have low vision to get around. So if we take a long cane user, when they're trying to cross the road, always to cross at a controlled crossing, is what we would recommend. So I'm sure everybody's familiar with the tactile paving that you come across on the approach to a crossing. Long cane user, as the cane tip hits that tactile paving, it starts to bounce up and down. The way the tactile paving is laid out will lead the long cane user to the control box, where they can press the button, and then as they bring their hand down and under the box, there's a little cone shape to the right underneath the control box. And if they hold on to that, when it's safe for them to cross, that cone will begin to turn. It's very important that people use the correct cane for them. So it might be a symbol cane, which is a short 3 or 4 piece cane, not to lean on, but it's just what it says it is. It's a symbol of their visual impairment. And it's saying to other people that the person who's carrying it needs a little bit of extra help, a little bit of extra space, and a little bit of extra time. They might be issued with a walking stick if they need the support, so it would be a white support cane that we would issue. We produce the talking newspapers for the area. It can be very frustrating for people when they can't read the newspaper. They like to get the newspaper. Maybe they can manage the headlines, but then can't manage any further down. So we compile the talking newspapers for this area. And it's actually produced onto a memory stick, and we can get about 11.5 hours of listening onto that. So the individuals have the speaker at home. The Talking News department, they do all the recording and copy onto the memory stick. They put it into a pouch, like so, and that goes out through the post to the recipient. They unpack it, put it into the speaker, and they've got their local talking newspapers. And this goes out every week, and we have about 650 listeners.
The company faces a maximum £20,000 fine on each charge, and it will be sentenced at a later date.
My name is Stephanie Beasley. I'm the volunteer coordinator at Envision, and my role involves recruiting volunteers for each different department of the organisation and placing them within that department. One of the questions that a lot of people mention that people tend to struggle with once they have reduced vision is watching television, and this can be quite difficult for people. But nowadays, audio description's available on television, and what this does, it explains the silences. Audio description is also available at theatre as well and in cinemas. So if people have enjoyed doing things like this, there's no reason why they shouldn't actually continue to do this. Same with sporting events. If people have enjoyed going to football matches, audio description is available now at a lot of the football games. Shopping can also be a problem. That's another area that's mentioned quite often. And it's more to do with the prices and the sell-by dates. Because a lot of the people that we deal with have macular degeneration, they do struggle at the supermarkets. But again, although our clients tend to be independent and want to do things on their own, if they're feeling a little bit under the weather and need that little bit of extra support, they can actually go to customer service departments. A lot of shops now have customer service departments where they can go along and they'll allow someone to go around with them to do the shopping that can check sell-by dates and prices and things like that.
We have a whole host of talking clocks and watches, or it might be that it's just the type that has a high contrast, which doesn't talk, but because of the way that it's laid out, it may be easier to see. But then the talking clocks...
The time is 3:21 p.m.
And it also gives
The time is 3:21 p.m. The date is 25 March 2014, Tuesday.
So that's a very basic skill, and somebody's got that right by the side. An easy one to have by the bed, so it makes it easy for people. And as I say, there are a whole host of talking clocks and watches, but I always say it's the voice that somebody can live with, because some of them aren't as good as the actual talking clock that we demonstrated there. Something else that people should be able to do is to actually be able to use the telephone. So we have the BT big button phone, and here we go back to the colour contrast. So there are nice white numerals on a dark background set again into the white of the phone, and always the 5 on any keypad has either a dimple or a raised notch on it so that people can find the centre of the keypad. There are cordless varieties as well, and another of the phones is that sometimes people have reduced vision and maybe they have the onset of some dementia and can't always remember numbers, but this phone actually you can put photographs in so that people can press that into the memory so that they can reach their relatives. We've got a full range of magnifiers, but we are lucky here to have a community low vision scheme. When somebody loses their sight, they actually have difficulty signing their name. It either goes up the page, down the page, or off the page. So having something like quite a simple signature guide, which just fits onto the paper, gives the individual small space to write in, to sign their name, and that again can keep it straight and helpful. And it's no good just writing bigger with a biro, because that doesn't produce the outline and the contrast that people need. So if they can use a good quality felt tip, then they'll get the contrast and possibly be able to read it back once they've written something. We do large print diaries and address books. People seem to like this little pocket diary, which again, clear print and quite a big space for people to actually be able to write in. You can get talking tins, which is like a lid. It's magnetic, it fits on, and you would possibly have to have somebody to help you to actually do the recording. So you record onto here, and then it will... So it will repeat back what is in that tin. I think those are very expensive. And something that is much more suitable is the Wiki Sticks, which are like a waxy pipe cleaner. And these can be moulded into any shape. So, and then they stick. So you can form it into an S, which is tactile on one of your storage containers. And they work also in the freezer, so you can put them cooking instructions or on tins, whatever. And they're much cheaper and can be reused, so I prefer those for labelling than the talking tins, which, as I say, I think are very expensive really for what they do. Although you could use them for leaving a message for somebody. We have talking scales, talking kitchen scales and talking bathroom scales. We have a talking microwave. So this will actually repeat back to you every instruction you give it.
High power, 1 minute, 10 seconds. Start, high power, 1 minute, 10, pause, cancel.
And a talking combination of them, but I think sometimes it's better to have a very basic microwave that we can mark up with bump-ons, these little orange tactile markings. So if you've got one of the cheaper ones, then we can actually mark up the dials on the microwave, because these are quite pricey. We talk a lot about lighting, and lighting's incredibly important, but we have the problem when people are outside and they experience glare. So March, September, those months when the sun's very low in the sky, then people really suffer with glare, and that can be quite disabling. So to have a pair of overglasses, they wear glasses all the time, because what we don't want to do is to reduce their vision anymore. So it may be a type of overglass like that, because it's built up across the top and at the sides, so it keeps a lot of the glare out. There are different ranges. These are quite cheap at £6, and these go up to, these are retailing at about £18. Better quality glass and possibly more cosmetically acceptable. Because we don't want to reduce the vision anymore, maybe some people would prefer a visor. It does exactly the same job, it just keeps that glare out of their eyes. And a hat with a brim will do exactly the same thing as well.
This is a little gadget called a liquid level indicator, and it has 3 metal prongs which sit on the inside of a cup or a glass. And it will do exactly what it's called. It will measure the level of the liquid and it will bleep, as I will demonstrate now. So we normally suggest to anybody that they actually put their cup onto a small tray. This is so in case they do spill anything, so they're not having to mop up the kitchen units. So they pop their cup on top of the tray, and then as you pour the liquid into the cup, once the liquid touches the bottom prongs, it will start to bleep. If this was, say, a cup of tea, somebody wanted to add some milk to it, then you can add more and it will start to vibrate around the cup. And no liquid has been spilt.
Today's Society for Vision Impaired People is a lot easier because you have a lot of technology out there. One is this reading device. You put a bit of paper like this underneath the camera and press one simple button.
Table mode.
And it will take a picture.
Choose the Optelec Clearview one, a generous size. 19-inch screen combined with a wide magnification range.
Also, you can have it running through a Clearview CCTV as well if you want to look at what it's reading as well at the same time.
Bank statement and utility bills, all can be seen.
Also, we have little devices like electronic magnifying glasses, what you can put onto the print and change the level of magnification, and it's just a matter of taking across the screen. It takes a little bit of getting used to for visually impaired people, but once they have got used to them, they like them very much. Also, there's CCTV where you put your print underneath it and it's on a table and you can move it around. Also, you can blow it up to very large print just by simply turning the little wheel at the bottom. Also, you can change the contrast to different colours as well. So you have all different colours to whatever you like, would suit your eye condition. Also we have technology like a Birrell mouse. They're one of the cheaper options where you can just place it over the print, connect it to your TV and just run along print as you want to read it. Obviously on a larger TV it's a far better item what's on this TV here. It takes a bit of getting used to for the older customers, as a shaky hand is very difficult, as you can see. Here we have a tablet. You can use these if you're blind or partially sighted. It is just a matter of touching the screen and it will tell you what to do.
Skype, make free voice. Skype menu, page 1 of 1.
And to go back,
main menu, page 1 of 4. Emails, send and receive emails.
all you have to do is let go of the button once it tells you what it is, and it will go to emails.
Email menu, page 1 of 2. Compose new email. Compose new email, page 1 of 1. Address book, select contact to email from address book. Select contact, page 1 of 2. Brian Casey, Brian at Envision. Please type the email subject.
And then you would just compose your message for the email. It's fairly simple. After about an hour's lesson, most people can email and access the internet with this without even looking at it. So, and also you can do that with the mobile telephone as well, with a similar software. Also, there is several computer packages, software packages, what enlarge the print and read. This one is Guide, for example. You have SuperNova and ZoomText and several others. This one is a basic model for people who could be partially sighted or blind. You can use it just by pressing different keys and it will talk to you what it's doing. You just read the screen and off it goes. This is the high end of the range. This is ZoomText, also with Dragon software, and we have a large 27-inch screen. At the moment the icons are a normal size, but just by pressing Alt and plus you can make the screen go a lot bigger. So we've got icons a lot bigger. You can go up to times 50 on the screen, so it's for all types of vision. Also, obviously if you're going to look at your CDM, this is how it would look. Again, you can go up and down as you want all the way through it. Also we have speech. A speech like that. And you can have all different accents if you want to do that. Also we have a Clearview reader where again you can also make the print go as large as you want and as small as you want. Again, changing colours and contrast. Also with this one, if you tap the screen.
Speech on. Position the text inside the window and tap the screen.
It will read the actual print. Eventually.
Envision. A visionary blind society in the Northwest, Spring 2014. We are a local charity for local people. We are a local charity for local people as an independent local charity. Also
you can pause it and play it as you want. Also you can record all that onto a memory stick as well if you want to record it onto a memory stick so you can keep it for future reference. That's what I've always found being visually impaired. It's really hard to find all these things unless you're at a centre like this or you go to the RNIB, but there's not that many centres around the country, so there'll be a lot of people around the country who don't ever see anything. Someone phoned me up yesterday from an optometrist but didn't know about this place. And it was on the LVA scheme as well. So I find that quite hard to work out because I've been started going around to different optometrists in Fleetwood and Cleveleys, and some are a bit more proactive towards us and some aren't. Some have got our newsletter and leaflets, and some have got them under the counter and don't use them. So I suppose it's sort of spreading the word and get the optometrist on side, I suppose. Because I go to Moorfields, you get to find out everything there. They can tell you everything, so it's quite good. But then as soon as you come out of their area, well, then you're stuck unless you've got a place like this. But I found it hard. Before I come to work here as a volunteer, it took me 3 or 4 months to find this place. I knew there was a blind society somewhere, but it was hard to find.
It's very important that we support people emotionally from the time of diagnosis. It's very easy for people to feel that they're on their own, and maybe they've been told that nothing else can be done medically to correct their vision. But there is a great deal that we can do to support people and to help them to remain independent, which I think is a big fear for people when they're first diagnosed. And so we'd address the emotional side of sight loss from the very beginning. We liken it to a journey of discovery, both about the individual and about the world around them. And we're here to accompany people on that journey that they make, and it's not always an easy journey. And I think for some people it's that feeling of having to say goodbye to the sighted person within themselves, and if we can accompany them through that difficult part and see them on their way towards acceptance.
What can you do? Find out what the services are in your area, work together to improve the sight loss pathway, and don't forget the LVL leaflet. Don't assume that a patient that has low vision will have automatically had support. Ask them what support they need and help them to access it.